Hi, I am Alex, and today I will be discussing on one of the errors in nursing. So, on this fishbone diagram here, we've identified the several different factors that have contributed to errors. These include equipment, process and procedures, communication errors, environment, and people. Today we'll be focusing on communication errors. The error that we have identified and are going to address on is communication errors with regards to handovers between nurses. Handing over is one of the most important part of nursing and shift changeovers. It has been identified that handovers are a risky time in the care process where information may be lost, distorted, or misinterpreted. So, what are the relevant national safety and health quality service standards that apply to this? Well, they are clinical governance, communicating for safety, and partnering with consumers. So, our aim for this trial is to reduce communication errors by 30% with regards to handovers between nurses within the ward by the 31st of December 2019. So, who are the people involved in this project? Well, they are the nursing staff, the patients, and the researcher or observer. The coordination of sufficient communication between healthcare professionals through handovers has become a crucial aspect for patient safety, quality healthcare delivery, and continuity of care. A study found that poor communication is the main contributing factor of 65% of sentinel events. Ineffective handovers are also responsible for about 22% of nursing incidents. Despite this, there are currently no overarching standard policies that apply to all healthcare providers surrounding how handovers should be conducted. Nursing handovers often lack structure without following a framework, causing inconsistencies in the information being handed over. The accuracy of information during handover is also influenced by staff factors such as teamwork, job demands, the environment, for example noise and distractions, communication style, level of experience, and knowledge. All these factors, such as the inconsistent handover policies, the lack of structured handover, and staff factors, can contribute to poor handovers and open gaps in communication, making handovers prone to errors, which can result in a cascading effect towards adverse events. These adverse events include an increased risk for medication errors, sentinel events, delayed treatment, increased hospital stay length, and decreased patient satisfaction. To address this issue, we propose 3 interventions. Firstly, nursing handovers are to be structured using the ISBAR framework, which involves identifying and introducing the patient and yourself, explaining the situation including current diagnosis and clinical problems, background, which includes patient's medical history, assessment where the findings of vital signs assessments and physical assessments are explained, a recommendation of further plans to manage and monitor the patient. Following the ISBAR framework provides structure ensuring that all the important information and all aspects of the patient's care is communicated, preventing the inconsistencies in the understanding of the patient's situation. Our second intervention is that handovers are to be bedside handovers, involving the patient in the process and ensuring that they are aware of their progress and the clinical problems they currently have. This ensures patients are actively involved in their care and are aware of the plans for them, so that they can identify nursing errors, communicate this to them, and potentially prevent adverse events. Lastly, interventions should aim to reduce distractions to the nurses during handover, such as the use of handover vests, similar to those being used during medication rounds. Minimizing disturbances during handover prevents nurses from forgetting to communicate key pieces of information and ensures consistency in handovers. The interventions we'll be looking at today are ISBAR, bedside clinical handovers, and the reduction of distractions. Today we're using the PDSA cycle to help us plan ahead. So the first intervention we'll be looking at is ISBAR. Our aim of our test is to implement and reinforce the use of the ISBAR framework and to trial success within the ward. Our prediction is to increase the communication and use of ISBA framework in the day-to-day practice of the staff within the ward. So this trial will be completed within the span of 1 year in the surgical ward. There will be a control group, which will be 6 months of observation, nothing implemented, and an experimental group, which is 6 months with implementation of the ISBA framework. Will be done in the same ward, same conditions, same hospital, and same staff, overlooking 2 shift changes. And now do. We're going to carry out the trial for 1 year. We're going to say 1 compulsory 2-hour module educating staff on the use of ISBA, and provide quick highlighters or reminders about ISBA with all nurses during general shift handover. And now study. We're going to analyze the data to observe how ISBA is used within the ward. We're going to ask the nurses to complete a survey ranking the 3 strategies used during the trial. With the top 2 strategies, we're going to ask them, why do you think it works best? And then we're going to compare the data with the predictions. Act. If the implementation of the ISBA framework is successful, changes will be made to improve the process of implementation, and thus we may begin to look at making this a hospital-wide guideline. Now, bedside clinical handovers. Our aim of the test is to implement and enforce the use of the bedside clinical handovers and to trial success within the ward. Our prediction is that bedside handovers will be introduced into the culture of the ward and be completed at the beginning of every shift. And now do. We're going to have a half an hour to 1 hour seminar on the newly introduced practice. We're also going to have a senior nurse accompany nurses along their bedside handovers, supervising them and providing pointers or advice along the way. Now study. This plan will be consistent throughout all the 3 trials, as they will be studied and tried simultaneously. So what's next now? If the implementation of bedside clinical handovers are successful, changes will be made to improve their process of implementation, and thus we may begin to look at making this a hospital-wide procedure. Finally, the reduction of distractions. Our aim is to reduce the number of distractions during handovers or during the transfer of information from one health clinician to another. Our prediction is that the number of distractions are to be decreased, increasing the efficiency of handovers or nurse-to-nurse transfer of important information. So now do. The use of handover vests or distraction vests may be implemented to make other staff aware of what is happening. We're also going to increase awareness about the distractions and the results and causes of distractions. So now study. It is hard to analyze the number of distractions experienced, so it is best to provide surveys, quizzes, or questionnaires to health practitioners involved in the trial to evaluate the levels of distractions during the course of the trial. And now act. We're going to look at what changes are made and what's the next steps. All of these will be looked more into the next few sections in the impact and information.
To ensure the results of the study is accurately obtained and recorded, different methods have to be used to collect data. As the study relies on the nurses and hospital staff's cooperation as well as understanding of the task, therefore gathering feedback and making sure the tasks are well understood by participants is crucial. As suggested by teachers' use and perceptions of progress monitoring improves students' motivation and helps them better evaluate the effectiveness of their instruction. Therefore, frequent progress monitoring can positively impact the ability of staff to follow instruction and lead the experiment to success. Gathering qualitative data through an interview is as important as gathering quantitative data collected from incident reports and surveys. Due to healthcare settings being unpredictable and accustomed to rapid change, in many situations nurses have to change their routine, usual practice to adapt to the needs of patients. After shift changeover, once a month, participating nurses will conduct online polls and interviews to discuss with researchers how the intervention has influenced their practice, both positively and negatively. Every 3 months, patient feedback surveys and performance observations will be conducted to gain more coherent and accurate data. And finally, at the end of the experiment, data such as incident reports, nursing notes, and shift change notes are collected. Quantitative data are plotted and graphed, and comparison of the data from pre- and post-intervention is made. This comparison will also have to be cross-checked with interviewers and their data to ensure the data shows correlation with the outcome of the experiment. To ensure successful strategies are well adapted and used in all routine handover, continuous monitoring, reporting, and planning following the experiment is necessary. Continuous monitoring will ensure the intervention enables nurses with tools such as feedback to use for future improvements. Reporting and planning for imminent changes is required to ensure the progress made through these strategies does not disappear as systems and processes revert to old ways of doing things. Ongoing monitoring can be done through randomized visits where an inspector will visit the hospital unbeknown to the nursing staff and request to observe the methods used during handover. Randomized visits by an inspector every month can ensure all staff members have a clear understanding of the intervention and the correct handing over techniques. Peer monitoring, on the other hand, can provide positive advice and feedback from a bystander's view, which then can be discussed in a group meeting. It also ensures the flow of handing over is not interrupted. Both monitoring processes will provide instant feedback to the nurses and be able to identify potential limitations of the intervention. Continuous reporting includes collecting data and feedback from incident reports, polls, interviews, and public yearly hospital performance records. Data will be collected from patients, hospitals, staff, and all members of community anonymously, which all aim to provide better quality care and focus on improving communication within the hospital. By gathering feedback and limitations of the intervention, future improvements can then be planned and implemented. Compulsory education programs and routine meetings should be held once every 3 months to ensure new strategies and interventions are continuously being reviewed and changed to better suit the environment and to ensure changes are sustainable.